Thank you all and welcome. Hi, I'm Bill Kasman, founding director of GeneWorx Capital, and welcome to another edition of the GeneWorx Discovery Series, where we feature science, people, and ideas from the leading edge of life science. Today's event brings another leading edge science and healthcare breakthrough to your attention. If you're a Star Trek fan like me, you'd love to get your hands on Dr. Leonard McCoy's tricorder, a handheld device that non-invasively scans the human body to diagnose injuries, disease, and infections. We're not quite there yet, but today's presenters will share with you how new imaging software called ElucidVivo can deliver amazing clinical insights from a routine, non-invasive computed angiography. Cardiovascular disease is a pandemic. 1 in every 4 deaths in the US is caused by cardiovascular disease, 1 in 3 worldwide. Each year, 805,000 people in the US go to the hospital from heart attacks. 3/4 of those are first-time heart attacks. Even worse, 1 in 5 heart attacks is silent. Damage is done, and you aren't even aware of it. Today, we're going to hear from a company that has developed a powerful new weapon against this pandemic, a non-invasive imaging diagnostic that can diagnose cardiovascular disease early before it's too late. ElucidVivo combines quantitative measurements of plaque morphology with advanced algorithms and machine learning, enabling early diagnosis and precision treatment for cardiovascular disease. Imagine improving stroke prediction by 40%, reducing clinical trial costs for cardiovascular therapies by over 50%, and avoiding 1.1 million unnecessary cath lab procedures in the US each year. How might drug developers leverage never before possible clinical insights to create the next generation of cardiovascular medicines, extending precision oncology techniques to the personalization of cardiovascular disease management? GeneWorx is excited to introduce you to our presenters today, Dr. Matthew Budoff and Andrew Buckler. Dr. Budoff is an investigator at the Lundquist Institute, professor of medicine at UCLA, and program director and director of cardiac CT at Harbor UCLA Medical Center. He's an expert in advancing procedures for early identification and treatment of patients at high risk for cardiac events and progression of atherosclerosis. Dr. Budoff's publications include over 50 books and book chapters and more than 2,000 articles and abstracts. Among his many professional accolades are appointment as the endowed chair of preventive cardiology at Harbor UCLA Medical Center, a gold medal from the Society of Cardiovascular Computed Tomography, Master of the Society of Cardiovascular Computed Tomography, and induction into the European Academy of Sciences. He's been recognized as one of America's top doctors for 9 years running, US News Top Doctor for Cardiology, awarded the Albert Nelson Marquis Lifetime Achievement Award, and named among the world's most influential scientific researchers. Andy Buckler is the founder, president, and chief technology officer of Elucid, where his groundbreaking work on 3D imaging and AI has led to the development of ElucidVivo. Andrew holds a dual affiliation with the molecular biology team at the Karolinska in Stockholm. He's been a pioneer in molecular and quantitative imaging for over 30 years with over 70 publications. In addition to his research, Andy has led engineering teams at Eastman Kodak, Hewlett-Packard, Siemens, and Philips, launching dozens of products that collectively have produced over $1 billion in revenue. Andy is the program director and co-chair of the Quantitative Imaging Biomarkers Alliance, an international organization uniting researchers, healthcare professionals, and the industry to advance quantitative imaging and the use of imaging biomarkers in clinical trials and clinical practice. Dr. Budoff and Andy will present for the next 45 minutes. During the presentation, put your questions into the Zoom Q&A tool, and we'll reserve 10 to 15 minutes at the end for Dr. Budoff and Andy to respond. So let's get started with our discussion of fighting the cardiovascular disease pandemic. Leading off, I'm pleased to introduce Dr. Budoff.
Well, thank you so much. Today, I wanted to start by discussing the prevalence of cardiovascular disease. I think we have to keep in mind that this is a global disease. It's the leading cause of death in all developed countries, and it's currently responsible for about 1 in 3 deaths. The COVID pandemic has made this worse because people have not sought out preventive care, and the numbers are undoubtedly going to go up. over the next few years. Currently, 70% of patients are considered low risk by standard screening methods at the time of their first heart attack. So they're misdiagnosed initially and considered low risk, even though they're having a myocardial infarction. We now lack individual disease phenotyping. We're not categorizing this appropriately. We use population-based medicine instead of individual therapy or categorization for patients. So our current methodologies for risk assessment are currently suboptimal. It leads to unrecognized disease in approximately 20 to 30% of patients. Over half of cardiac catheterizations are unnecessary. This leads to a huge incremental cost and burden to our patients and to our healthcare system. And there's currently minimal alignment of therapeutic to individual patient disease. In other words, a lack of precision currently used in cardiovascular medicine. Drug development and treatment for cardiovascular disease currently is not cost effective. Unnecessary cardiac catheterizations alone lead to over $10 billion in wasted spending each year. There's an avoidable catastrophic events further increase spending. Think of all of the myocardial infarctions, strokes, and other events that occur because of misdiagnosis or underestimation of risk. And the cost of cardiovascular disease drug development is huge, with a difficulty in adoption that makes innovation uneconomical. These costs of drug studies are so large because we're enrolling lower risk patients into clinical trials and not enrolling appropriately high risk patients who may benefit from the specific therapy.
So as Dr. Budoff has said, for the lack of specific markers, cardiovascular disease trials often take years to reach the primary endpoint. And this has a delay in terms of the benefit of those trials. And if they don't meet those endpoints, it's a devastating effect that can make a promising therapeutic not possible to bring to market. Coronary catheterizations are expensive, and they're, whereas they do measure helpful signal, they're in general limited, mostly focusing on arterial structure and indices or scores associated with plaque composition as opposed to direct measurements. Imaging-based studies have the potential to reduce time, cost, and risk, but they themselves can take years to show statistically significant regression or progression if the markers that are being used as a result of the output of the analysis lack the methods which achieve the specificity and the signals that they're there to produce in the first place. And as a result, many CVD therapeutics are competing for utilization. What we'd like to have is that strong and differentiated clinical evidence brings forward clear mechanism of action backing for these therapeutics for the benefit of patients. More specifically, as we consider optimizing drug development with the benefit of the data sciences, including techniques for managing data and analyzing that data with artificial intelligence techniques, we're seeking to reduce the time in the identification of promising drug candidates by identifying the signal earlier, reduce the cost through non-invasive assessments and identification of mechanism of action, seek smaller trial sizes by identifying the highest risk patients and likely responders ahead of time, reduce unrelated adverse cardiovascular events from oncology and other therapeutic trials, increase the impact by measuring the biology without need for infeasible or impractical arterial biopsies, increase the efficiency, accuracy, and trial data fidelity in measuring clinical efficacy and during trials. And last but not least, to enable tailored therapeutics during clinical care, especially for cost-prohibitive drugs which can't be used across the population in a broad-based manner. ElucidVivo is a breakthrough FDA-cleared tool in the fight against cardiovascular disease in general, as well as specifically appropriate for use in helping with the development of therapeutics. The approach that that this analytical method takes, which differentiates it strongly, is starting from a histological ground truth basis. What this means is that there is an objective definition of tissue type as opposed to a subjective or qualitative impression-based method from radiology. And that enables the opportunity to view radiology as a quantitative assay, more along the lines of what the multi-omics generation of technologies has been so helpful for in other disease areas. Looking at the way this works, we use exemplars from histology, both in terms of the optimization of the tissue characterization algorithms and ultimately in its validation. It creates quantitative plaque morphology assessments at an exquisite level of granularity, which exceed what has been possible before. This is a combination of image processing techniques and artificial intelligence modeling, but also has a strong mechanistic tie to the bench sciences and the decades of scholarship, which has led us to biological insights into the disease. The result of that is the ability to identify at a very granular and objective level the tissue types which are the drivers for atherogenesis and which either confer stability or instability in terms of how those tissues are developing over the course of time in patients. The number of measurements which are made possible by this approach exceed those of legacy software, and not only the type of measurements, but as well the accuracy of those measurements in terms of describing the disease.
So this is a specific study that employed the ElucidVivo model, looking at the effect of biological therapy on plaque progression and regression. This was a prospective observational study in 209 biologic naive psoriasis patients. They either underwent biological therapy, 124 of these patients, or no biological therapy in 85, and were followed over baseline and 1-year visits. So they underwent baseline CT angiography and blood samples. They had characterization of lipid-rich necrotic core with the ElucidVivo model to determine how the lipid-rich necrotic core modulates in response to biological therapy over time. They then came back for a 1-year follow-up visit with both blood sampling and CT angiography. And then we evaluated the maximum lipid-rich necrotic core area and maximum remodeling ratio determined for each major cardiac vessel using the ElucidVivo software at both baseline and 1-year visits. The nice thing about this model is that patients do not have to have significant coronary artery disease to look for these. Historically, we could only evaluate patients with this level of detail in the cardiac catheterization lab, and typically they'd have to have significant disease to be imaged with intravascular ultrasound or OCT or other invasive modalities. Now we have significant sensitivity to identify lipid-rich necrotic core non-invasively. So you can see here the effects in the trial. If you look at the change of lipid-rich necrotic core over 1 year, you can see biological therapy induced a regression of this lipid-rich core. There was a minus 0.15 millimeters squared with a significant p-value of 0.028 for biological therapy, where in the no biological therapy group, there was progression of lipid-rich necrotic core with a significant increase in plaque. If we look at this patient example here, you can see at baseline, the lipid-rich necrotic core in yellow and calcification in green. And then the 1-year follow-up, you see less of that lipid-rich necrotic core, less yellow on the slide, and slightly more calcification over a 1-year study. So we now have an early stage, non-invasive tool to follow patients over time to look at the effect of different therapies. We also use this tool in the EVAPORATE trial. I was the principal investigator of EVAPORATE. EVAPORATE was a trial to evaluate the effect of icosapent ethyl over changes in coronary plaque characterizations. Patients underwent a baseline CT angiography. It was a randomized, double-blind, placebo-controlled trial. We originally enrolled 80 patients and randomized them to either placebo or 4 grams of icosapent ethyl per day. Again, it was double-blinded. We then followed those patients at 9 months and had a repeat CT angiogram and ultimately another CT angiogram at 18 months. The study enrolled patients with elevated triglycerides who had atherosclerosis at baseline, and they were followed using this software for plaque characteristics, including lipid-rich necrotic core, fibrous cap thickness, and intraplaque hemorrhage as being assessed. We use multivariable models to assess the changes and evaluate for plaque progression or regression under the different influences of either placebo or icosapent ethyl. Here are the results. We had a total of 60 patients at 9 months who had interpretable images at baseline and 9-month follow-up for the analysis. Relative to placebo, patients on icosapent ethyl demonstrated decreased wall volume. You can see wall volume decreased in the icosapent ethyl group, -7.2 versus progression under the effects of placebo. There was a decrease in the lipid-rich necrotic core, -1.4 millimeters cubed as compared to slight progression in the placebo group, and increased cap thickness. So the fibrous cap got thicker, stabilizing the plaque. It increased by a positive 100 microns under the effect of icosapent ethyl, where it decreased under the effect of placebo over this 9 months. So basically, we saw a migration of atherosclerotic plaque to a more stable phenotype in those patients treated with icosapent ethyl. Here you can see an example of the placebo. If you look at the green values in the slide on the left, you can see the lipid-rich necrotic core volume was 132 over the course of 9 months on placebo therapy. The lipid-rich necrotic core went up. The minimal cap thickness went down, so the cap got thinner, less stable. Overall wall thickness increased under the effect of placebo, so there was more overall wall thickness. And in this example, interplaque hemorrhage also increased over these 9 months. So in summary, we see that these changes, things like lipid-rich necrotic core and wall thickness increasing, fibrous cap decreasing, indicative of moving to a less stable phenotype under the influence of placebo. This is a patient who is on active therapy, and we basically saw the opposite. We saw lipid-rich necrotic core decrease. We saw the minimum fibrous cap thickness increase, again, moving towards a more stable phenotype. We saw maximum wall thickness decrease and interplaque hemorrhage decrease. So overall, on drug therapy, we were able to see a more stable phenotype at 9 months follow-up. Keep in mind that with icosapent ethyl, we've already seen in a large trial, the REDUCE-IT study, clinical benefits with decreased outcomes. So this provides great mechanistic insight into why we're seeing improved outcomes under the influence of icosapent ethyl, now understanding how it's affecting this vulnerable plaque characterization. So we now have never before possible plaque morphology measurements. These were literally subjected to only patients who went to the cardiac cath lab with that invasive investigation. We can now do this as an outpatient in a much less invasive approach using just intravenous contrast and CT imaging. And the model performance identifying relationships among quantitative plaque changes and responses to drug therapy. You can see here the lipid-rich necrotic core going down, the minimum fibrous cap thickness going up. We also saw a small signals and other measurements as well, enabling a more granular understanding of drug metabolism. And these data corroborates the drug effects in FDA filing.
So as Dr. Budoff was saying, what we are interested in is ElucidVivo's ability to document mechanistic rationale for plaque changes based on drug action, and with this, the opportunity to support adoption. So staying with the example of the icosapent ethyl that Dr. Budoff started, at baseline, we're able to identify the characteristics of plaque burden, showing quantitative magnitudes of stenosis, localized wall remodeling, calcification, lipid-rich necrotic core, and intraplaque hemorrhage. So the natural history of patients that are on placebo, which have not the opportunity to be benefited by the drug, we see changes in each of these plaque measurements, and have the opportunity to then correlate those to changes that we see in the biological signals. And in particular, we see that levels either remain stable or increase that confer instability in terms of the plaques, and as a result, the poorer outcomes of patients that do not receive the drug. Those patients that do receive the drug have a very different pattern, and it's that different pattern that we're able to quantify, and that which contributes then to the documentation of the drug's actual effect in terms of measures which are causally tied to the outcomes that we have observed in other trials like REDUCE-IT. It provides an unprecedented ability to longitudinally track changes in time and to adjust for age-adjusted ranges, stratified by events or therapies. And I have two examples here. The first in carotid disease, where we've stratified on the basis of whether there has been a stroke or a major adverse neurological event. And in the particular graphs that we see here, these are graphs that are available for the very first time, that have a level of granularity and accuracy to them that can tease apart the small differences that make large differences in patients' lives. In the coronary disease example, in this particular case, the stratification is on the basis of biologic therapy. These particular graphs having been taken from the psoriasis cohort that Dr. Budoff had summarized earlier, but with the opportunity to see the actual quantitative changes in these measurands with the different stratification variable. This capability can be pressed into service for a variety of other drug developments, whether they be early or later in their development cycle, in order to provide the level of documentation needed to help FDA approval of the therapeutic, as well as post-marketing in terms of the ability to prescribe it and have it reimbursed.
So here we can see the potential to reduce the size and risk of clinical trials with optimized patient selection. So with lack of specific markers, cardiovascular trials often require thousands of patients. This leads to a ballooning cost and risk that the trial may be negative because they're enrolling the wrong patients, or not enrolling patients with the specific factors that may benefit the most from the individual drug. For non-CVD trials, including those for oncology, we often have extremely negative results if the patient suffers a major adverse cardiovascular event or stroke during the trial, potentially due to no fault of the therapeutic itself, but of course, the FDA invokes a negative connotation for that drug if this happens in an unbalanced way with the therapies at hand. Inclusion or exclusion of patients at high risk for MACE or stroke, identified through a non-invasive pre-assessment, can dramatically reduce clinical trial size, cost, and risk of getting a false negative study. Even more specifically, identification of likely responders to a therapeutic based on a patient's individual disease amplifies these benefits exponentially. So this is one study that looks at MACE, major adverse cardiovascular events. This was called the postcard study, looking at plaque stratification using CTA and coronary artery disease. It was a retrospective pilot study for the Medical University of South Carolina for coronary CTA. They enrolled 640 patients, 3-year follow-up study, which is still ongoing. They looked at cap thickness. They looked at lipid-rich necrotic core volume, lesion length, and positive remodeling ratio, and looked for the association of these endpoints with major adverse cardiovascular events, or MACE. You can see in the slide, the green is how well stenosis performed to predict MACE events. The area under the curve was 0.7, certainly better than chance, but look at the improvement by adding more morphological measures. And now in yellow, we were able to identify with an AUC of 0.95, huge improvement in the area under the curve, a 30% improvement in the prediction of cardiovascular event risk by using plaque morphology measures on top of CT angio. And keep in mind, these images were already obtained. So this is just further analysis. There's no additional radiation or patient burden or scanning required to get these additional measures using ElucidVivo software. It also improved major adverse neurologic events, or MAIN prediction. This was a 200 patient retrospective study across a number of medical centers, including UMMC, the VA, Cleveland Clinic, and Cornell for carotid CTA, with up to a 6-year follow-up for MAIN. They now have a total of enrollment of 350 patients as we continue to look at this specific question. This is called the CRISP study, or the CRISP consortium. And you can see that the methodology include looking at matrix, occupancy of the matrix, lipid-rich necrotic core area, inner plaque hemorrhage, and calcification maximal area were all associated with intracarotid artery plaques ipsilateral to the stroke. You can see here, if we just use the NACIT analysis, the area under the curve was 0.55, not very good prediction. We had a 40% improvement in prediction of neurological event risk by plaque morphology. So as we think about adding these to MACE or MAIN, we could potentially reduce clinical trial size by up to 50% with prediction of those patients at baseline who are more likely to suffer an event, or more likely to benefit from therapies, and really dramatically reduce clinical trial size. So here we can see, as we think about the generalized model here for the clinical need, we have these currently therapeutics that may lead to suboptimal outcomes, not being too specific with who we enroll. So new or existing cardiovascular disease therapeutics may have a powerful positive effect on certain population of patients, but we may have reimbursement or clinical barriers to widespread use. These limitations often result in underutilization of an effective therapeutic to the detriment of patients, providers, and payers. So the next generation non-invasive identification of likely therapeutic response based on a patient's individual disease can improve outcomes and increase therapeutic utilization for patients.
So if we think about the future, then there's a need expressed for the ability to tailor therapeutics by the individual as opposed to being limited to population-based statistics. What we've seen is that statins confer a large benefit on a population level, and we've made great progress in the field on the basis of their use. In order to go deeper, though, we know that there are an increasing number of other drug classes which could be given, however, for a variety of reasons are not given, whether it be because of cost or be because of side effects, by giving those patients to non-responders. So the ElucidVivo's scientific roadmap is moving forward to provide ever more increasing granularity so that we can get down to trial sizes, if you will, of the N of 1 and individualize the patients. This has been popularized in the popular mind as precision medicine, largely associated with cancer. However, what we'd like to be able to do is to also make cardiovascular patients benefit, provide that benefit to cardiovascular patients with techniques which apply to the specific requirements of cardiovascular disease. A large part of that, of course, being that you can't biopsy the plaques. And that's a big difference with oncology. So what we're looking for are non-invasive methods in order to do that. And that is what the ElucidVivo is increasingly able to provide. If we look how we're approaching the issue, the first is high fidelity image processing. And in particular, we've already seen results in image restoration, for example, to increase the signal to noise ratio, despite technical and other characteristics of the images, which unprocessed are suboptimal. And then we've discussed the histologically validated plaque tissue characteristics and phenotyping, which is made possible by that. And Dr. Budoff has reviewed a couple of the specific examples that we've done in some drug trials in terms of the benefit that that brings. Now what we have started to publish on as of this May in the ATVB is non-invasive expression profiling. This takes it down another scale or deeper scales for a multi-scale analysis from the macromolecular presentation at CTA down into the cellular and molecular level activity, which is undergoing in a particular patient. The way we are approaching this problem is to take the histologically based tissue characterization, which produces the virtual tissue models, and add an additional level of ground truth basis from multiomics data. The May ATVB paper has started that using microarray-based transcriptomics. Present work is extending that to other multiomics data sets. But in this particular published result, what we were able to do is to build virtual expression models that utilize the true expression as a ground truth as well as a validation point, much like the previous described work uses histology. And in particular, what this yields then on an individual patient basis is the dominant mechanism. For example, cholesterol metabolism, various inflammatory cascades, endothelial epithelial to mesenchymal transition in the cytoskeleton, etc. Those processes which are understood to be associated with atherogenesis. In this work, we were able to determine robustly some number of hundreds of transcripts which are implicated in the disease process. And whereas this at first seems like it would be very difficult to do, has been demonstrated in that result and in work that we're pressing forward. So specifically, if we start with the image processing, move to the phenotyping, and then apply these techniques in such a way as to get the expression profiling, ultimately what we are able to consider is the opportunity to have an accurate description of the dysregulated biological processes that can allow for determination of what different drug classes that patient would be most likely to be able to respond to. The dominant mechanism of the plaque phenotype then can be used in order to achieve the goals of precision medicine in cardiovascular disease. And so if we look at that particular work, which I had alluded to from ATVB, and we take 2 of the test patients, we can demonstrate a little bit of the power of the technique. So the top patient shows clear signs of a cholesterol metabolism origin of disease, which would highly likely have that patient be a responder to intensive lipid lowering. That drug could be prescribed with confidence to that patient because other patients do not have such a signature. And as a result, the societal cost pressures would be mitigated. Give that to patient A, because patient B is unlikely to respond to it, might respond to a different therapeutic. Patient B shows signs of that could be a responder to colchicine, for example, as an anti-inflammatory, but not just anti-inflammatories in general. What specific anti-inflammatory might benefit that patient? And as a result, both patients benefit, and the societal cost burden is optimized.
So as we think about the overall utility of what we've been reviewing today, we really have the ability to assess both plaque rupture risk and ischemia, all derived from plaque morphology. We can measure fractional flow reserve and plaque stability from a single CT angiogram, again, non-invasively. It leads to an avoidance of up to 83% of unnecessary cardiac catheterizations. Invasive angiograms can be reduced by eliminating some of the normal and more stable patients. We have a 30% improvement in assessment of rupture risk. We have a reimbursement now of between $1,100 and $2,600 in the US. And this technique is now mandated in the United Kingdom. It's led to increased cath lab profitability. It's supported in the clinical guidelines, including in the 2021 chest pain guidelines by the American College of Cardiology and American Heart Association. And as you can see, we do and can achieve accurate estimation of invasive FFR from this morphology-based CT angio assessment. In a study of 113 patients looking at plaque morphology, we had an area under the curve of 0.95 with a sensitivity of 79% and a specificity of 88% for invasive FFR measures. So we have a non-invasive tool that now nicely emulates a much more invasive and costly tool, invasive FFR, done again with existing images from the CT angiogram.
Okay, so we're ready to get started with Q&A. And let me switch to gallery view here. Thank you for an excellent presentation. Let me see what's come in here. Okay, we can lead off with this one for Dr. Budoff, but I'll let you guys just kind of choose how to kick it around. But I think this is an interesting lead off one. I'll paraphrase it. So the question is, do you see elucid ever being used as part of a pre-symptomatic routine preventive medical exam? But maybe I'll have you extrapolate it a little further. What's it mean to the patient? So we kind of went through all the science. So I'm a patient and there's this new tool available. What does it mean to my patient experience? When is it used and what'll it mean?
Yeah, I think there's a lot of patients out there that really want more advanced measures than just an estimate of stenosis to say, oh, you have a 30 to 50% prox LAD, and that's good enough. So I think there are patients who are going to be very interested in getting more advanced plaque metrics. Obviously, from an insurance standpoint and from a user standpoint, we'd like this driven by, I think, the physicians. But I think that it could become part of a routine patient experience where we first go through the stenosis severity, and then we kind of talk more about some of these advanced metrics and what the implications are.
Okay, great. Did you have further comments on that, Andy?
I think what Dr. Budoff has said is right on target. I guess the question becomes, as we realize that the bench science has taught us that stenosis is actually a relatively later stage in the disease progression. It's essentially when an outward remodeling process earlier in the disease reaches its limits, and so now it remodels inward. There's a whole part of the disease process which is just fundamentally not captured by stenosis at all, irrespective of whether it is effective later on or not. And so, whereas at this time we're not necessarily recommending a broad-based screening program or something of that kind, which might be an aggressive change in policy, what we are doing is we're setting up those rudiments, if you will, or those capabilities that could go in directions like that for patients, whether they have family risk factors or they have certain lifestyle issues which might put them at rest. They might be interested in this earlier. And then later on, depending upon how this progresses, that kind of capability might take place, and we can start to manage cardiovascular disease more on a chronic basis rather than waiting until it's a late stage disease. So those are the capabilities that we see in front of us. Right now, we're focused largely in the management and the optimization of patients that are suffering from the later stages of the disease. But this capability for the first time has at least the ability to start reaching back.
Mm-hmm. Okay, great. Here's a couple sort of specs ones. Is the software FDA cleared?
I'll pick that up. It is. Essentially the measurement of lipid-rich necrotic core, an accurate measurement of calcification burden, as well as accurate measurements of structural anatomy and matrix, is on the market, cleared by the FDA now. Our roadmap is increasing the ability to, we presently have intraplaque hemorrhage, which is in the regulatory mix, as well as the development of interpretive models. Our hope is that people could see this is something to get started with now, and it only gets more interesting and more exciting as we go forward.
Okay, here's one perhaps for Dr. Budov. What clinical insights become possible or might become possible as you combine the elucid images with other patient clinical data? It's a little bit of a futures one.
Well, I think that as we start seeing these more vulnerable plaques, these different metrics that we are not used to seeing or not easily seen on CT up until this software has become available, I think we can imagine a place where we can really get a wonderful explanation for risk. And we can think about metabolic syndrome, or we can think about diabetes or other diseases where they're more likely to have these more vulnerable plaques, and maybe tie it back to their patient care and their other therapies. And I could see, for example, myself thinking more about maybe a GLP-1 receptor agonist for a diabetic with this type of plaque issues as compared to maybe a different therapy. So I think it's going to tie back in over time to the patients.
That's really interesting. Here's a couple more sort of spec-based questions. Does this do the same? Does this do the same thing as heart flow? Maybe put context on heart flow for those who don't know what that is.
Yeah, so I'll just start with heart flow. I'll let Andy talk about how this is a little different or similar to what we see in heart flow. The heart flow is a purely AI to look at FFR, fractional flow reserve, as an estimate based on CT images. And they've done quite a bit of work over the years validating this technique with trials and validation against invasive FFR. And that's all they do. They don't give you plaque metrics. They don't give you other metrics that we've seen with this software. But it is purely focused on giving you an FFR CT map. And if there's a stenosis, you can see what that estimated fractional flow is. And the lower the number, the worse the flow, the more physiologically significant it's the implication.
That's exactly right. I'll just build on that just a short bit. We recognize that there are multiple things that can be negative in the patient's lives. One is stress-based angina, as you need additional blood flow. FFR is what has become known as a very effective method for that, and HeartFlow is able to measure that, and we applaud them for it. We observe that fractional flow reserve originates in dysfunction in the vessel walls. And because of that, the plaque morphology measurements, which we have an exquisite measure on, is actually able to provide that FFR measurement, we believe, in a more direct manner than what other methods might be able to do. But we go further, and that is, it's not only flow limitation, but as well it is the propensity to rupture. And so those morphological characteristics that confer the risk of actually breaking and causing myocardial infarction is also made possible by the morphological analysis that we do. So in addition to FFR, we're also able to catch that other phenotype. That phenotype is actually more associated with sudden cardiac death. And with that, there's a more comprehensive overview completely. Even the FFR, we consider not only to be the more direct measure, but we can actually provide what amounts to the explanation for a given FFR value. We have heard that some other methods, sometimes clinicians are wondering why the number came out the way it is. In the method that we use, there's the opportunity to directly appreciate that based on both the visual as well as the quantitative assessment that's provided.
Okay, great. I have a question that's come in from a Mr. Bora. Is there a direct or indirect technique to detect collaterals after the plaque to area of coronaries?
So I'll pick that up. So we have actually seen evidence of collaterals. I think it's an application that we haven't focused on right now. But we do have that opportunity. One of the benefits of being a non-invasive assay as opposed to being a catheter-based assay is we do a full field of view assessment. And with that, not only the primary vasculature, but as well any adaptive collaterals are being picked up. And that might have implications for what we do going forward. You know, in a way that that makes this you know, even more interesting. It's not an area we focused on so far, but it's possible.
Okay, and can we differentiate wall calcification versus plaque calcification?
So wall, there is no difference. All calcification is intimal in the coronary arteries. So it's it's in the wall, but it's also plaque. It's considered atherosclerotic. And there's really 100% of coronary calcium is considered atherosclerotic plaque. So medial calcification occurs in peripheral vascular beds that are elastic, not muscular. And even Mockenberg, who described this, said it doesn't occur in the coronary arteries. So any calcium we see is atherosclerotic, and it's in the intima of the wall of the vessel.
Okay, and here's skeptic's question. Can you avoid coronary angio if sensitivity is only 79%? Do you miss 21% of positive cases?
So I think that's for event prediction. I don't think that's not sensitivity for obstruction. Sensitivity of CT angiography is always north of 95%. I don't know of any study in the current literature that puts it at a lower than 95% sensitivity for obstructive coronary disease. I wrote the first multi-center trial on the accuracy trial, which was a 64 slice platform, which is rather old now. I wrote that paper, I think about 14 years ago, and we had a 95% sensitivity. I think if you're talking about event prediction, nothing is perfect to predict events. Obviously, events can occur in any possible domain and from many causes. But I think the fact that we can better predict events so much more than these other models, like NASCET or other models, that I think is very, very has great enthusiasm by preventive doctors to be able to use this as a marker of somebody who's higher risk and therefore more likely to suffer a cardiovascular event.
I'll just briefly add that in one of the studies that we reviewed here, it's subclinical disease for the most part, where coronary artery disease is not the primary indication, but a comorbidity. The fact that we're able to pick up signals there portends well for the ability to work even in disease settings beyond obstructive disease. These are the potentialities of the methods that we're using.
Okay, and just kind of picking up on that topic a little bit, what measurements drive the event prediction models?
So I'll pick that up. The lipid-rich necrotic core is obviously very important. We're also seeing significance in the intraplaque hemorrhage. This method, for the first time, can provide within CTA an accurate method for cap thickness. The IVUS cap thickness can get down to cap thicknesses of about 150 microns. This method can get down to about 180, so we're getting very close to what the catheter-based methods can do. So a combination of lipid-rich necrotic core, intraplaque hemorrhage, and cap thickness is what we typically see. I'll just further say about calcification. We do see an equivocal signal in calcification. Calcification can actually confer stability depending upon how it presents. It can also portend poor outcomes as well. Largely, this in our work so far has related to both the size and location, as well some initiatives that we have underway for identifying microcalcification is the aspect of calcification which might confer instability. So this is what we're seeing right now.
Okay, and then two more compounded specs question. Can you analyze femoral arteries, and can you see intramyocardial fat? These aren't necessarily related questions.
So what was the first one?
Can you analyze femoral arteries?
I'll leave that to Andy to talk about the applicability of this to others. The second question was about intramyocardial fat. Very easy to see, very easy to quantify on CT. Fat is much different, lower density, and therefore stands out. So yes, it's very easy to see intramyocardial fat and fat related to infarcts, like rarefication of muscle due to infarction. So that part is easy. I'll leave Andy to discuss the peripheral.
Thank you. And we do have a direct read on perovascular adipose tissue as well in the coronary space, as recent scholarship has been suggesting that is also a measurand of interest. And yes, the femoral artery is one of the arteries which is supported in the FDA-cleared product.
Okay, great. We're getting closer to the end here. I'm going to do 3 more questions. What's the difference between this software's plaque quantitation and METIS? Another specs question.
I mean, they use different tools. I think there's obviously different engines that they're built upon as well, but METIS doesn't do vulnerability of plaque at all. It just measures quantified plaque. I don't know if there's a head-to-head study of this technique versus METIS, but they're just slightly different in their acquisition and measurement of plaque volumes. Where the new software that we're talking about now has just much better capabilities of looking at markers of plaque vulnerability, lipid-rich necrotic core, fibrous cap thickness, things that we really, I think, are going to be very interested in as being a more vulnerable plaque and therefore a more vulnerable patient to need therapy with. METIS is purely quantitative plaque per segment.
Yeah, and I would say that's right on. I guess from a tech point of view, the basic underlying difference has to do with the level of sophistication of the tissue characterization algorithms and the validation relative to histopathologic correlates. In many of the other softwares, whether that be METIS or otherwise, oftentimes there are Hounsfield unit thresholds which are used to separate tissue types. But the overlapping cellular and molecular level milieu of the tissues causes the densities to overlap. So the ElucidVivo algorithms specifically are created in such a way as to tease apart the overlapping density spectrums, if you will, and with that provide accurate measures. So the lipid-rich necrotic core, as Dr. Budoff was suggesting, is an objective histopathologically defined term, and that's what ElucidVivo measures. It's not just sort of low attenuation plaque underneath a threshold. And then at the high end, because we use an image restoration technique that more accurately delineates the calcification blooming, well-known blooming artifact is mitigated, and there's an accurate calcification signal. And because the lipid-rich necrotic core and the intraplaque hemorrhage are properly delineated, there's the opportunity as well to do something which is well beyond the scope of most software, and that is intraplaque hemorrhage. Each of these capabilities being a result of the nature of the algorithms which are used, which go well beyond Hounsfield unit thresholding.
Okay, great. And I have two short answer questions, one for each of you, and then a futures question to wrap up with Dr. Budoff. CT myocardial scar versus fat. Back to the intramyocardial fat question. Can you see those differences? Is that a clear question?
I'm sorry, I don't understand the question.
Okay, we'll take that offline. One quick one for you, Andy, is can the software analyze existing scans on our packs?
Yes, the software is relatively tolerant of a wide variety of different scanning protocols, and we do not intentionally specify scanning protocols. There are some limitations of what can't be scanned, but for the most part, the algorithms have been designed to be very tolerant of anything which is clinically acceptable, broadly speaking, in the field.
Okay, and then kind of put you on the spot, Dr. Budoff, for our wrap-up question. With elucid and current and future drugs in development and this idea of precision cardiovascular disease, how long until heart attacks and strokes become rare events?
Well, I mean, our goal is to eliminate cardiovascular disease. Unfortunately, with the pandemic, heart disease remained the #1 cause of death, about 3-to-1 over COVID. And I think because of the behaviors and the public health messages being to stay at home and not see your doctor, I think heart disease is going to continue to go up. So I think we're far from that, but I think this moves us in the right direction. Being able to identify the high-risk person will allow us to identify the high risk, to see the high risk plaque, will identify the high risk person, and we have really excellent tools in our tool chest, statins, PCSK9s, icosapent ethyl, other therapies that we could use to help lower CV risk once we identify the high risk individuals. I'm enthusiastic that better stratification will allow us to treat our patients better.
All right, great. Well, thank you, Dr. Budoff and Andy Buckler, for sharing your work and the amazing promise of this breakthrough technology. And thanks to all of you in our audience for participating in this GeneWorx Discovery Series, where we feature science, people, and ideas from the leading edge of life science. We'll follow up with a link to a recording of today's event, and see you next time, and have a great holiday season.